Good afternoon, or rather good evening now. So I applaud your stamina and your thirst for knowledge, or the CME points for that matter, I don't know. And it's my honor and privilege to welcome Dr. Hasan Baydoun, consultant and chief of orthopedics and sports medicine at Healthpoint, and he's also my physician. So thank you. Keeping with the theme of obesity as a multi-organ disease, he's going to talk about obesity and the musculoskeletal system. Floor is yours.
Thanks so much. It's so good. Thank you. First of all, it's so good to be here, seeing a lot of familiar faces. And I'd like to thank the organizing committee for actually including me on this. When Mohamed initially approached me, it was a Sunday, I remember very well. And he's like, Hasan, I want you to speak in the UAE Obesity Conference. It took me a couple of minutes thinking, why is he inviting me? I'm an orthopedic surgeon. Does he know something about me that very few people know? And then I'm like, you know what? I'd be honored. This is something which is very dear to my heart. And I'll tell you in a couple of minutes why. So I also practice at Healthpoint and at Mubadala Health Dubai, part of the M42 network, soon also in Sharjah, hopefully. And I'm a sports and shoulder surgeon. I've been in and around locker rooms my entire life. That's what I do. That's what I love to do, ACLs, shoulder surgery from A to Z. And I'm not typically around obese patients. I've done Ironman myself, so you can imagine that I've been a fitness freak for a while. That until I share with you that I've been around an obese patient for the majority of my life. And this takes me back to when I was growing up. Another one of those photos, and another one of those photos. So at a BMI of 37, this is really where I was not morbidly, severely obese, right, Dr. Haddad? Severely obese. And I didn't get a chance to go through those slides so that we can accommodate for the new nomenclature, but still. So that's why I did not even hesitate, but I thought he knew where I was coming from. So very quickly, we're going to talk a little bit about the outline of this talk, and I'm going to run through those topics one after the other. I'm going to give you a brief background, go through some myths and misconceptions, and talk a little bit about obesity, both adult and pediatric population. So this is going to be my summary slide as well. The background for this talk is that, and I'll read it verbatim, obesity negatively affects all musculoskeletal disease processes, be it the incidence, the treatment considerations, as well as the outcomes. And weight loss remains the mainstay of all effective treatments. If you're going to do something, it's not something surgical. It's weight loss remains the mainstay of most effective. There's a large disease burden both on society. The WHO estimates there's more than now 1 billion people who are either obese or overweight. And in the US population, 80% are estimated to be overweight, and it's increasing. This used to be a disease in the developed world. Well, no more. It's even in the developing world. And the orthopedic burden happens across everywhere. But it's important to stress, even as an orthopedic surgeon, that this is not just a problem of the adipose tissues. This is not a weight problem. This is a systemic problem. It is a chronically inflamed state. We have to look at the body as an entire system. I can't stress that this is not just a musculoskeletal problem in my case. This brings us to literally what Dr. Haddad was just talking about right now. You have to take a more general approach, a more holistic approach to those patients. Because yes, perioperative management is more complicated, but I'm guilty. I'm an orthopedic surgeon, and if you know one, we only care about 3 things: bone, tendon, ligament. That's all I know. That's my nomenclature in medicine. I've forgotten everything else. But in reality, we have to take a step back so that we can understand that we are actually treating a patient and not a fracture. So this bird's eye view is extremely important. A couple of myths and misconceptions about obesity and musculoskeletal problems that I'm just going to quickly touch upon. So the first is that it's a biomechanical problem. Well, it's not just simply the excess of weight which affects us as orthopedic surgeons, because there's been a clear link between the inflammatory mediators, leptins, cytokines, and cartilage degeneration. Matter of fact, yes, it is more apparent where there is more stress on hips, ankles, and knees, but it's still present in the obese patients, in the hands, where there is no effect of the excess weight. So this is a systemic condition, and that's why you have to take a look at everything going on in the body. And when you take a look at that, you understand that the treatment of musculoskeletal disease in the obese patient is going to change. The paradigm shift will be that we're not going to be treating localized problems. We have to take a step back and also start thinking about immunotherapy for the treatment of those patients. Bone density is better with obesity. This stems from the misconception that when we would get astronauts coming back from space, their bone density would be crap. Pardon my French. Well, we understand that we have extragonadal estrogens that also adds as a protective factor. We have increased weight on the bones. That adds as a protective factor, but it does not offset the added weight. Plus, there is a negative correlation between fat mass and bone mass, mostly due to leptin. You're going to hear me talk about the same things over and over again. You're going to hear the words inflammatory mediators several times through this talk so that I can stress the importance that this is not just a mechanical problem. This is an inflammatory/hormonal problem. And that's why now we're shifting our research in osteoporosis so that we can understand how leptin modulates that. A third misconception is that the soft tissue is going to protect us from injuries. Well, yes. This is a bubble boy effect, right? And we've all watched that movie with Jake Gyllenhaal, and possibly true. And I say possibly true because there's two sides to this story. In low energy trauma, we do see a paradoxical increase in comminution. That low energy trauma meaning falls from height without motor vehicle accidents, without a moving object, okay? Knee dislocations, for example, will have a much higher risk of neurovascular complications in the obese patients. In high energy trauma, our mortality rates are much higher in the obese patients. You talk to a general surgeon and he'll tell you that if you have a motor vehicle accident, that's not the case. And yes, there is the momentum equation playing here, because with increasing mass, you have a higher momentum of a moving force. And the abdominal girth will protect from intra-abdominal and chest wall injuries, but it does not do that for fractures. It actually increases the strain on the pelvis, increased risk of pelvic fractures, and increased risk of long bone fractures with higher comminution. So it becomes a larger disease burden, and we're already faced with the increased risk of complications that those patients have. And the last myth and misconception is that the patient will lose weight after surgery. Orthopedic surgery is not weight loss surgery. I have to stress that. I'm going to stop for a second and say that again. Orthopedic surgery is not weight loss surgery. At best, at 1 year, 14% reduction. At best, 14% of patients had lost weight. And this does not, so the others did not lose any weight, and that might be related to the pain and their ability to actually have a higher activity level, but that is not a true correlation, okay? It's the same concept. You can ask them to lose the weight before and after the surgery. So the next topic that I'm going to be talking about is going to be actually about obesity in the pediatric population. And this is what is very dear to my heart, because remember, I was severely obese as a peds and then started losing this weight into my mid-20s. This is an epidemic. 30% of the US population, the pediatric US population, is now overweight or obese. And those are kids that are running around like crazy. I mean, I sometimes wonder, when I sit at dinner with my 7-year-old daughter, I'm like, how's she burning all of those calories? If I ate what she ate, I'd balloon again. And there's a reason for that. Kids on average, relative to their size, take about 3 times more steps than an adult. So just imagine that. So they are at a biomechanical advantage when it comes to burning that caloric intake. And we're still at a 30%, plus they're in a growth phase, so they're at a 30% incidence of obesity. And that has its impact, because when you're obese, it impairs your mobility, and then that's where the cascade starts kicking in. When the cascade starts kicking in, you see the specific problems that come with pediatric obesity: Blount's, slipped capital femoral epiphysis, flat feet, and what complications that come. And I'm going to take a couple of those specific diseases because they're only specific to the pediatric obese population. Those are not things that you see typically in the non-obese population. And think of the hip and the femur as an ice cream scoop sitting on top of a cone, okay? And that's the ball of the hip, and you have the femur as the scoop. If you apply too much pressure in one direction, and it's not a straight force, as you can see, so it's not a straight line. If you apply too much pressure, you actually start slipping that head off to the side. And that's the reason why you have skiffy. And initially it presents as a very small limp. They complain of a little bit of pain, but then in severe cases, they can't walk. One would think that, as I mentioned earlier, this is a pure mechanical problem. Well, guess what? No, it's a hormonal problem as well. They're in an increased growth spurt, so their epiphysis is actually weaker to accommodate for that growth. The extra weight leads to that stress, and that's why a lot of times it presents on both hips. Here's the problem with this diagnosis. This is one of the very few true surgical emergencies in orthopedics. So whenever you diagnose this, you must intervene immediately. Pediatric hip is already complex. You have deformed anatomy. You have obese patient in already a small patient. And that's why you can understand that this is not simple surgery. You need to refer those to physicians who are actually handling a lot of those, a dedicated pediatric orthopedic surgeon. Blount's disease follows the same concept. The mechanical axis of the knee sits on the inside of the knee, medial to the knee. That's because the weight goes central. So if you have added weight, you're going to start creating more stress towards the inside, and that's why you get this bowing in those obese patients. Unlike skiffy, this here is not limp pain. This is mostly a deformity problem, and it manifests early on. So imagine putting a 3-year-old in something like this for the rest of his pediatric age. Another 10 years of bracing a kid. Imagine the psychological stress it would cause on kids that age. That's why it's important to treat the problem in this case before it even arises. Weight loss is the key to treatment. Again, one of the themes of this topic. Surgery, of course, if there's a problem as an orthopedic surgeon, I'm always going to recommend a surgical intervention. But no, if we can prevent it, an ounce of prevention is worth a ton of cure. Again, higher complication rate because of several factors, but one of those factors is that the culprit of this problem has not been removed. The culprit, which is the added weight. So the recurrence of Blount's disease after surgical fixation remains the biggest problem in this case. What about fractures? And that poses another problem in the pediatric population for several reasons. One, we use flexible wires, so the implants are different. Those implants were made to support X weight, not 2X weight in this case. So we have to use adult implants. And when you use adult implants, it's a different ballgame because you have to cross the physis. We have growth to take into account in this case. Add on top of that, pediatric crutch craning is not easy, so you end up with a big problem where you not only have to cast, not only have to surgically treat, sometimes have to do both, and the added societal burden on the patient who's actually going to school on a daily basis. And the last, which I see as a pandemic in the obese population, is painful flat foot deformity. The arch of the foot is maintained through the pull of the posterior tibial tendon. There's a superior pull on the arch which maintains it so that it can elevate it. And this allows for proper biomechanics of the entire lower extremity. So if you put an excess weight on a car, it's not going to actually function correctly. And that's why the arch will completely collapse. Treatment, again, will be weight loss to ease the problem. If that's not an option immediately, non-weight bearing exercises, swimming, eccentric loading works as well. And last but certainly not least is the impact that obesity has had on the adult musculoskeletal population. And if you're gonna see one theme again, and I put this in bold, is that weight loss remains of paramount importance. I hope that there's no orthopedic surgeons in the room, but if you want to treat this problem, it's not through us. It's actually through the holistic approach of the underlying problem. I can treat the symptoms, I cannot treat the problem. And I'm gonna talk about each and every one of those very briefly, but you'll get the gist of the talk by the end. Knee arthritis. The same way that Blount's disease happens, knee arthritis happens. There's a mechanical problem on the inside. And BMI has been correlated negatively with alignment. So you'll get severe knee arthritis whereby the medial joint collapses in. And the more mechanical malalignment you have, the higher the momentum of the force, and it becomes a vicious circle. But remember, it's not just the mechanical stress. Cartilage oligomeric matrix protein has been isolated in those patients. Muscle mass is lower relative to the body weight. And even when there is no malalignment, there are cartilage defects in patients with an increased BMI. Again, to stress the fact that this is a systemic hormonal problem. Hand arthritis. If you think of it, when you have an overweight patient, they don't gain weight in their hands. Why do they have a higher risk of hand arthritis? And that's again, because leptin will act locally in the tissues, and it's actually been overexpressed in the synovial fluid of the obese patients. Low back pain, both mechanical and systemic causes. And it's through several reasons. The first is the association with BMI, so there's the added mechanical stress. We can consider, this is one of those areas where we can consider bariatric surgery as the weight loss regimen because those patients cannot bear the weight until they get the pain relief. And a lot of times they have hypertension, so you can't give them anti-inflammatories. Injections are typically very short-lived in this population, and non-weight-bearing exercises, such as in a pool, are recommended. But what about the outcomes after surgery? This is one of the areas where the outcomes after surgery actually do good. So yes, orthopedic surgery is an option in the low back patient who is a good surgical candidate. And that's where it comes back to selecting your patients right. DISH, another cause of low back pain, non-surgical, but it's extremely common in patients who have been obese, or even if they've lost the weight. And you can see how you get literally autofusion so that they can support the added weight. Soft tissue disorders, and it's from A to Z. What I'm getting to here is that obesity does not necessarily just affect one joint, it affects the gamut of everything. It's increased the neck, shoulder, ulnar nerve entrapment, carpal tunnel disease, that's on the upper extremity, rotator cuff, something that I love, trochanteric bursitis, everything from a Morton's neuroma, plantar fasciitis, it affects all orthopedic problems. And what about the outcomes? Yes, we do have significant pain decrease after bariatric surgery. So if you want to address the underlying problem across the board, don't address the orthopedic symptom. Get the patient to see somebody who will counsel them on their weight loss, irrespective of how that is done, through nutrition, through weight loss meds, through surgery, but that's how you need to address the majority of those orthopedic problems. Weight loss is key. That is the treatment. Gait disturbances. And this is also related to the biomechanical stress on the lower extremity. And the way I explained this to the residents when I had some is think of this as a single wheel that is out of true. If you have one single wheel that is out of true, you're going to have a gait abnormality, and that's going to lead to the rest of the tires wearing down and eventually the chassis of the car getting messed up. And that's how you need to approach this. So gait abnormalities are correlated with BMI. And you can't get an orthopedic surgeon to sit on a stage without talking at least a little bit about surgery. Total joint arthroplasty is an option for those patients who do have arthritis. They're beyond medical treatment, but we have to counsel those patients. Just like Dr. Haddad just said, you have to get what we call informed consent. Because those patients have an increased, and I'm sorry it's morbidly obese, Dr. Haddad, not severely obese, but they will have a higher risk of infection, higher risk of in-hospital death, PEs, DVTs, intraoperative complications, length of stays, increased incidence of going to a care facility. So their care is much more complex. And should they do this total knee before bariatric surgery or after? And unfortunately, there is no evidence to support that you can get the bariatric surgery done to decrease the complication rate after a total knee or a total hip. So the complication rate, even if they'd lost the weight, remains high. To stress the fact that this is an inflammatory problem, which is now a systemic problem. It's not just a localized problem from the increased stress or the increased weight and increased covering of that joint. And infection remains the bane of our existence as orthopedic surgeons who do any arthroplasty. And this is the only thing in red that you're going to see in this entire presentation. 10x risk of infection in morbidly obese patients, in severely obese patients. 10 times. That's a risk that I cannot accept. But sometimes those patients are desperate, and it's understandable because of the pain. And that's the reason why we have to counsel those patients. You add diabetes to that, that's a 10% risk of infection. That's not low, because you get an infected joint, that's practically a disaster. That's an added 2 or 3 procedures down the line. And that's why the consent needs to actually discuss first and foremost the risk of infection after surgery. You have to counsel those patients. You see those patients as much as we do. They beg you for this surgery, for the orthopedic surgery, thinking that it's the panacea. But guess what? It can be the panacea, but no, it's not always the one-all be-all solution. So in summary, I'm going to finish my talk just like how I started it, and literally verbatim. Obesity negatively affects all musculoskeletal disease processes, incidence, treatment considerations, as well as outcomes. Obesity's effect on the musculoskeletal system comes from both the systemic processes as well as the added weight and stress. It leads to an increased disease burden across the gamut, and special considerations need to be addressed in the orthopedic treatment of obese individuals. And if there's one thing you're going to take from this talk, is that, again, weight loss is the key here. And I'm just going to tell you here that, yes, I did lose that weight, but on the flip side, I did gain a total hip down the line. So I know exactly where those patients are coming from. I understand their pain. And let me tell you one thing. I can't spend enough time counseling all of my patients on the importance of weight loss. Thank you.
Thank you very much, Hasan, for a fantastic presentation. Oh, there's a question over there.
I have 3 questions, but actually they're just comments. First, can you say hello to Tom Brady for me? I just want to go back. Yeah, go on.
Just speaking of Tom Brady, there's a lot to say about the guy just because of a couple of things. I learned from him that everything in life is a job. You'd see most of the other players on the field thinking that, yes, it's showtime and everything. But you cannot understand that when somebody shows up to breakfast and he's carrying a playbook, memorizing plays, not wasting a single second, you can't imagine the amount of dedication that that guy has put in to get to where he is.
Yeah.
And I saw that day in, day out when I traveled with them. Unbelievable.
Just going back to when you're talking about it's a systemic disease. So this is a question in the bariatric service and the obesity clinic. I think we need to screen for musculoskeletal disease. Don't wait till the patient complains of knee or shoulder pain, because I think early detection, early screening would help them to actually go into at least a physiotherapy program, and then they will develop the muscle. So if they need to have surgery, so total knee replacement, the muscle is not emaciated. And that's why I find that sometimes some of our patients, I'm in the endocrine clinic, so they get a total knee replacement. They're like, they can't really walk. I don't know, I trained in Ireland and I used to see them walking after surgery. So this is one. I think early screening and then referring them earlier to orthos is really important. The second thing is really a request from the orthos. Can we just reduce the frequency and the dose of steroids given? Because this is really, is a contention point, because they're like, oh, it's not going to affect your diabetes, it's not going to affect your obesity, and it does.
As in,
thank you.
Okay, that's actually a good point, because typically we use steroids as a last resort when medical treatment has not worked.
Yeah.
That's why you can see a lot of injections other than steroids, not to say non-steroidals, injections other than steroids gaining popularity in and around the market. Hyaluronic acid, PRP, even now adipose-derived stem cells. And yes, we do understand that risk and burden, but unfortunately, sometimes our hands are tied. And I understand it. And that's the reason why I use this mostly for personally, I use this mostly for diagnostic injections.
Okay.
I'll give the best example, and patients come in asking sometimes for that, to delay surgery, to avoid it, to not do surgery on the spot. And I'll always tell the patients, I've had orthopedic surgery. I did not get a single cortisone injection prior to surgery. I understand the risks of that surgery on my body. I understand the increased risk of infection after surgery. I did not want it upon myself, so I wouldn't want it for you. And that's how I personally approach it. Unfortunately, it becomes a little bit of a difficult conversation a lot of times with the patient when somebody comes in a lot of pain, expecting a miracle to happen. And that's where the problem. Repeated steroid injection is a complete and big no-no.
And just about obesity and diabetes, as diabetes in itself actually causes a lot of musculoskeletal disease. Have you seen, what would you talk about, say, rotator cuff, adhesive capsulitis, and so on? So just a comment if you, prevalence.
Especially for the shoulder, the only medical questions that I ask are diabetes, thyroid, and smoking. And that's the extent of my medical knowledge, because it negatively affects also everything from A to Z. Incidence is much higher, treatment options are very different, surgical complications are much higher. When a patient comes in with an acute rotator cuff tear, non-diabetic, risk of success is upwards of 90%. That goes to 70% if they are a controlled diabetic. So imagine the magnitude, 4 times higher, 400%. Those are conversations that we have to have with the patients, but we also have to stress the importance of diabetic control before surgery and after surgery. So yes, I agree with you. I'm an orthopedic surgeon. I'm guilty as charged that sometimes we hone in on bones, tendons, and ligaments. But yes, we do have to take a step back and actually treat the patients.
Thank you very much. That was one of my questions, was why is shoulder particularly sensitive to type 2 diabetes, or diabetes in general?
Extremely important question, and it comes back to actually, I hope that people believe in Darwinism here, from when we were actually walking on 4 limbs. And that's an existential question, because the shoulder in and of itself used to be a weight-bearing joint. But when we became primates and we became erect, we stopped using that joint for weight-bearing. You can see acromial morphology actually shifted completely out, and that's the reason why the rotator cuff completely went off to the side. Now, there is a rotator cuff around the hip, and that is the gluteal muscles. Okay? But those muscles, developmentally, we actually maintained them. When we became humans, okay, and with our increased life expectancy, those muscles don't function as much. We see in primates a much lower incidence of rotator cuff disease. In apes, we see that much higher because they actually have a longer lifespan. That's why rotator cuff disease, for example, is almost never present under 30 years of age. It's reportable under 20, okay? But it increases with age, and that's mostly related to lifespan. Diabetes affects muscle density, so sarcoplasmic loss, tensile strength of tendons, and that's the direct correlation. Diabetes, rotator cuff disease, age.
Thank you very much.
All right, thanks.